for you to tell them what to do. You're going to say, okay, I want you to lay on your back, I want you to lay in the middle, or I want you to lay slightly to my side, or slightly away. You can plan ahead and say, okay, I know I'm going to be rolling onto this side, I know we're going to sit up this way, I want you to start here. You get one shot. You can say, okay, lay down. Once they lay down and you're done directing them, that's it. That's where your practical starts, your competency starts. Fair? Okay, that way they don't jump into bed and they're all the way across the bed and you're like, I can't reach you to move you to the side. Okay, so that's your one shot. The other option is lowering the bed, makes it easier to reach across, but obviously your knee is stuck by that bed rail. In clinical practice, if that were to happen, a draw sheet would be what you would use. So instead of reaching across the patient, you would have a sheet, you would roll it up over a hand grip, and you would do the same movement as the textbook way, but your hands are on a sheet. That way you're not reaching as far away, you're protecting your back. Okay? We're not using that in the practical because we give you the option to position the patient. Okay? So no, it's not appropriate to do one of these just for your biomechanics. Fair enough. Sure, we've all thought about it. Any questions, side to side? All right, we're cooking. Another patient. All right.
Give you a little tiny present.
Appreciate it.
What am I doing?
All right, you go ahead and lay in supine, and go ahead and lay a little bit closer to that side. All right, so now we're going to be doing rolling movements, okay? Rolling is either going to end in sideline or going to end all the way over in prone, okay? So we're going to learn supine to sideline, supine to prone, and we're also going to learn the reverse. That way, if your card says position them in prone, we just transfer them back to bed. You know how to move them around within the bed so that they end in that position. Because what's one thing we said we never do? We're never pushing them away. We're never rolling them away from us, okay? Patients are always pulled towards the therapist. They're always rolled towards the therapist, okay? Hospital, it's a little bit different if you've got people on both sides. Someone's gonna be pulling towards themselves and you may be pushing a little bit. But here you're by yourself, always roll the patient towards you. So we gotta position the patient so that we can roll. First we'll do supine to sideline. Pillow, get it out of the way, thank you. That way it doesn't obstruct your movements. Her head is gonna look the direction we're rolling. Perfect. If they have the ability to do it, ask them to, otherwise you can rotate their head. The arm that we're rolling onto is gonna be in a reverse T position if they have the range of motion, the external rotation to get there. So it looks like this. The reason is when we roll onto our side, it's gonna be like a kickstand, a larger surface area than if it were just tucked here underneath the body. Her legs, the opposite leg is gonna come this way, so already I'm gonna start and cross the ankles in the direction we're rolling. Does it make sense if we did the opposite? That is kind of fighting, or it looks like her body wants to go away from me. So we're always gonna bring the opposite leg in the direction we're moving. Her free arm is gonna come across her chest, similar to what it was before when we were moving up and down. Is this still recording?
Mm-hmm.
Good, cool, just making sure. Okay, so we're here, we have bony landmarks that we need to put our hands on. Any guesses what those could be? And hips, right? So we're gonna use two hands, we're gonna get the entire trunk. We're not gonna jam our fingers, we're gonna lead with that thenar eminence, soft hands, we're gonna go underneath the patient, not just here on the side, okay? So I'm gonna lead here, underneath the scapula. Instead of being here where you might put pressure on their neck, or make them claustrophobic if you're covering their face, I'm gonna go here, make sure you're going around the trunk, here on the hip. What stance should my feet be? AP stance, same exact as moving side to side, and you're gonna help me if you can. We're gonna roll onto your side. 1, 2, 3. Did my arms bend? No, they stayed straight. That's me as a grader, I'm looking at your arms. If I see this, I know you just use your biceps. It's okay if the patient's small, but if you do that repeatedly, you're gonna hurt yourself. So I wanna see the arms stay straight. I wanna see an obvious weight shift onto that back leg, just like we've been practicing. If they bend, so let's go back onto your back. You want to do this, okay? If I see them bend, what I'm using them for is a block to stop the patient from rolling further. So I'm here, here. 1, 2, 3, and here, and then I bend kind of as a stop. That way she doesn't continue forward, and so she feels stable on her side. Patient's on her side, you're not gonna ever take your hands off the patient, okay? So if we're ending here, if it says leave your patient in left sideline, this is where you would leave her. You would position her with pillows, which is in your lectures in future units, where to put them for supports, where to put them for preventative positioning to stop skin breakdown. So we might pull this arm out. She can be on the bed like this, holding on, but you're never gonna leave a patient like this. So as long as the patient is in sideline, you have to have a hand on your trunk. That means from the shoulder to the hip. Doing this doesn't count if we're walking away to grab something, because you're not gonna actually help her from falling one way or another. So hand always on the trunk when the patient's in sideline. Because the next movements after we get done rolling is going to be sitting the patient up, which usually happens from a sideline position. So from here, hands on the trunk, and then we'd be doing something else. So you always need to make sure that hand stays on her. Okay? Some patients are gonna have trunk control, some are not. And it's better to be safe than sorry. Always assume that you need to have a hand on them. Yes?
If it was like left side affected by CVA, would you roll the other way or?
Good question. So CVAs, have you guys had conditions yet?
Yes.
You have, okay, that's why they moved this course up. So CVAs are fair game. What do you guys think about rolling onto a hemiparetic limb? Do you think it's beneficial? Do you think it's wrong?
I think it's beneficial.
Okay, why is it beneficial?
In some form of essentially put to the actual extremity.
Does anyone know what that's called? Proprioception, right? So, as a modality, proprioception, weight bearing, is advantageous to a hemiparetic side. So it is beneficial. You can roll onto it as long as there's enough integrity in that shoulder that you're not going to dislocate it. If it's subluxed, you may side against rolling onto it. But if it's an acute CVA, there's not going to be any subluxation immediately. It's still going to have enough muscle tone to protect the shoulder joint. Yes, you can roll onto this stroke affected side.
And he's saying it's beneficial in that whenever she goes to like push off to get herself up, she's using those muscles?
In theory, so that's neuromuscular re-education. So something you'll learn down the road. Putting weight on a limb, you've got receptors, such as with all my neuro patients, you've got receptors in each one of your joints. When you put weight on it, with your arms, standing is natural, you're getting weight bearing, it's sending an impulse to the brain that says, hey, there's an arm here, hey, there's a leg here, and this is the position, the orientation that it's in. So you're connecting the dots between those muscles and the brain, and you're trying to encourage muscle activation and body awareness, proprioception.
Facilitation.
Yes.
We use that at Stretch Lab. It's a contract and release method basically
Yes.
to elongate muscle fibers.
So it is beneficial.
Instead of crisscrossing the leg like that, could you bend the knee so that way it would offload the butt more?
To
just
get
your
in the
line.
sideline, or once she's
To
in
roll,
sideline?
like, so that way all you've been is, cause if you have them here, they're
Yeah.
offloaded already.
Yeah, so it depends where we're going. So from here, if we're going to leave her in sideline, we would do that to make a larger surface here. We put a pillow here and we'd bend her top leg so that it stops her from rolling. But from here, we're gonna actually be moving into a seated position. So this is fine because you're just gonna be pulling those legs off the bed anyway.
Okay.
Okay, so for the purpose of this, just so we cross the board, we'll just cross the ankles in the direction we're rolling, okay? So that is supine to sideline. So go back onto your back. We're gonna do supine to prone, and then we'll practice. Everyone good with that? That way you're rolling in one direction, and then we'll go prone to supine after. Okay, so again, my patient is here. Let's say I need to get her into prone. It'd be advantageous that I start her as far away as I can, because if she comes up in the sideline, then I need her to have enough real estate to have her lay in prone. Hospital beds, you're gonna have a lot more room to work with, as long as you can reach them appropriately. If you can't, you need to have them in the middle of the bed where you can reach them effectively, okay? So she's gonna start the exact same way. She's gonna look the direction that we're moving. Opposite arm's gonna cross across her chest. Ankle is gonna cross in the direction that we're rolling. The only difference is this arm. Reverse T is good because when we end in sideline, it increases that surface area. But if we're going all the way into prone, it's gonna get tucked underneath there if we continue rolling. the way up. Okay, get that arm out of the way. If we have enough range of motion to do that. Some patients are not. So you're always gonna check. If they've got full shoulder flexion, that's the orientation we want to get the shoulder out of the way. If they're restricted, if the case says only has 0 to 90 degrees of shoulder flexion, you're gonna tuck it. Okay, when you tuck the arm down here at the patient's side, you're gonna be palm facing up, palm facing the thigh. That way it kind of cups onto the body and you're not abnormally rotating the arm as you're rolling over. Okay? So if they don't have the range of motion, arm gets tucked at their side, palm facing the body. Ideally, out of the way. Arm being fully flexed is a lot more stable of a position. You're resting them on their trunk. This will feel very precarious to the patient. You will absolutely need to keep a hand on the trunk because they will feel very precarious because they're balancing on the outside border of their arm. Okay? But if that's what you have to do because of the range of motion limitations, that's what you have to do. Okay? Let's assume she's got full range for this one. She's above shoulder head. She's looking towards me. Bony landmarks are the same. My stance, AP. And it's a weight shift. 1, 2, 3. She rolls over. I stop her here.
Hold on, there's a big.
There's a crab. Yeah.
Oh, I was like,
That's what I've been
crawling.
freaking out.
Yeah. Oh, sorry.
He's just moving
I'm sorry, I
locations.
thought it was a
We've got
spider.
we've
No,
got
it's a
bunch of
crab.
different
You got
because
it.
of the river.
I thought it was a spider.
Oh, don't.
He just needs to go outside.
Is that indoor? I don't do.
I need some Pokemon.
I thought it was a spider. I was like, yeah.
Oh, here's this one.
Yeah.
Is that one empty?
Yeah.
No. Sideline.
Oh, there's coffee in there.
Oh.
And that's what happened.
There I
The
go.
patient's on the floor, the patient's on the floor.
Hold the patient in the
No! Don't you dare.
I just want to toss it out that door.
Onwards.
Gently.
That one works over here.
Check that one.
I'm sorry, I had to. I was like,
Just throw him right in the parking lot.
It's
that
not.
was a big
Good eye, you're looking
spider.
at